Welcome back to another session of the Deep Dive. Today we are shifting gears a bit. We're moving away from the abstract and getting right into the trenches of high-stakes exam preparation. We are locking the doors and turning the lights down low. Not for a romance novel, but for some hardcore physiological analysis.
This is the operational end of the spectrum. We are just discussing theory. We are discussing survival, specifically how to survive the anesthetic management of laparoscopic surgeries question.
And it is a guarantee, isn't it?
Right.
If you are sitting for your MD anesthesiology exams, particularly, if you are looking at the Gujarat University papers, this topic is practically glued to the syllabus. It shows up everywhere.
It is a staple, an absolute staple. You cannot walk into a postgraduate exam hall without having this mastered. And honestly, it shouldn't just be for the exam. This is the bread and butter of modern practice.
Right.
But the examiners love it because it is deceptive.
Deceptive how?
Because on the surface, it looks simple. Oh, it's just a lap cold. It's just a lap appendix. But physiologically, it is a minefield. You are taking a patient, blowing them up like a balloon, tipping them on their head, and poisoning them with mild acid, all while expecting them to remain hemodynamically stable.
That is probably the best description of laparoscopy I have ever heard. Minimally invasive for the surgeon, maximally invasive for the anesthetist.
Exactly. And that is the lens we are using today. Our mission is to synthesize the data from the heavy hitters. We're talking Miller, Morgan, Yao and Artuzio, and the Wiley texts into a narrative that is coherent enough to write down for a 20-mark long answer, or to speak fluently during a Viva.
Okay, we have a lot of ground to cover to hit that level of detail. We've structured this to mirror how you should structure your exam answer. Introduction, the core physics of pneumoperitoneum, the system-by-system physiological changes, management, complications, and finally, special situations.
Structure is everything. It truly is. If you are asked this as a long question, you don't just vomit facts. You build an argument. You lead the examiner through your thought process.
So let's build it. Part A, introduction and overview. You turn over the exam paper, and there it is. Discuss the anesthetic management of laparoscopic surgeries. How do you frame that opening to immediately grab those marks?
You start with a definition, but you need to be precise. You establish that laparoscopy is a technique allowing endoscopic access to the peritoneal cavity. But the critical hook, the phrase that Miller emphasizes, is that this requires the creation of a pneumoperitoneum.
You have to create space. You have to make that potential space an actual space.
Correct. You are intentionally creating a workspace between the abdominal wall and the viscera using gas. That single concept is the defining feature, and it's the source of all our problems. Without that space, there is no surgery.
And usually, the textbooks, Morgan especially, start listing the advantages. Smaller incisions, better cosmetics, reduced postoperative pain.
Those are the surgical advantages.
Yeah.
And yes, you absolutely list them. You have to.
Right.
But if you want to sound like an anesthetist, you focus on the pulmonary benefit. Why do we prefer a lap coal over an open coal? It's not just the scar.
It's because we aren't doing a big subcostal muscle-splitting incision.
Precisely. And what does that mean for the patient post-op?
They can breathe better, they can cough better.
Exactly. You have better preservation of post-operative lung function. You have less inhibition of coughing and deep breathing compared to a laparotomy. This means less atelectasis, fewer chest infections, and a shorter hospital stay. That's an anesthetist's answer.
However, there is a nuance here that Yao and Artuzio points out, which I think is fascinating. We talk about it being less stressful, but that's only true after the surgery.
That is a crucial distinction, an absolutely vital one for a high-scoring answer. The post-operative inflammatory stress response, the interleukins, the C-reactive protein, that might be lower. But the intraoperative hemodynamic stress, it is significantly higher than open surgery. You are subjecting the heart and lungs to a phenomenal stress tests.
So the introduction needs to set up that conflict. Post-op benefit versus intra-op risk.
Yes, that's the narrative. And that leads you directly into the three major forces. If you are writing this down, this is your framework. Yao and Artuzio lists three forces that alter physiology during these cases.
Let's list them.
Number one, the pneumoperitoneum itself, specifically the increased intra-abdominal pressure, or IAP.
Okay.
Number two, patient position. You are rarely flat. Yeah. You're usually in steep Trendelenburg or reverse Trendelenburg.
So gravity is working against you.
Or for you, depending on your perspective. And number three, the systemic effects of carbon dioxide absorption, the chemical effect of the gas itself.
That's the triad of trouble. IAP, position, CO2.
If you can keep those three buckets in your head, you can derive almost all the physiology. You can reason your way through any Viva question.
All right, let's deep dive into the first bucket then. Part B, pneumoperitoneum, the gas itself. Why do we use carbon dioxide? This is a classic question.
It's a classic Viva opener. Dr. Doug Watt, why are we using CO2? The answer lies in a balance of safety and physics. Firstly, and most simply, it is non-combustible.
Right. Diathermy, sparks.
We use diathermy extensively. You cannot use oxygen or air because you would literally turn the abdomen into a combustion chamber.
Which is generally considered a poor outcome.
To say the least. But the second, and arguably more important reason, is solubility. CO2 is highly soluble in blood. Morgan quotes it as being about 20 times more soluble than oxygen.
And why does that solubility matter so much?
It's your safety margin.
Mm-hmm.
Think about the worst case scenario. You accidentally inject a bolus of CO2 into a vein as a gas embolism. Because it's so soluble, the blood can buffer it rapidly. It dissolves, forms carbonic acid, and gets dealt with.
So small amounts can be absorbed without causing a major blockage.
Exactly. If you injected the same amount of air or nitrogen, that bubble stays a bubble. It's inert. It travels to the right heart, gets whipped into a froth, causes a vapor lock, and you have a cardiac arrest. CO2 gives you a get-out-of-jail card for small emboli.
Are there alternatives? I read about helium or argon being used in some experimental contexts.
They exist, but they are very rare for a reason. They are inert gases, so there's no risk of fire, and no acidosis because they aren't absorbed systemically. That sounds great on paper, but they are totally insoluble. So if you have an embolism with helium, it is almost certainly fatal. The risk-benefit ratio just pushes everyone back to CO2 every single time. It's the least bad option we have.
So CO2 is safer from an embolism perspective, but it's not perfect. It causes hypercarbia, and you mentioned it's irritating.
It forms carbonic acid on any moist surface. That's why patients get that referred shoulder tip pain. It's carbonic acid irritating the diaphragm.
Let's talk numbers. The surgeon is asking for more pressure. Can I go to 20? What is the hard limit we need to write down in our exam answer?
The magic range in the literature is 12 to 15 millimeters of mercury. Both Yao and Artuzio and the ICU texts are very clear on this. You should consider 15 millimil of Hg to be the inflection point.
What happens at that inflection point? Why is 15 the magic number?
Below 15, the physiology is generally manageable in a healthy patient. Once you go above 15 millimil of Hg, the physiological penalties start to steeply outweigh any improvement in surgical visibility.
And if you go above 20?
If you go above 20 millimil of Hg, you are entering the territory of abdominal compartment syndrome. You are compressing the vena cava so hard that blood literally cannot get back to the heart. You're also compressing the renal veins, the aorta. You risk total cardiovascular collapse.
So the takeaway is 12 to 15 is the safe zone. Okay, let's move to the heavy lifting. Part C, physiological effects. This is where the marks are. If this is a 20-mark question, a good 10 marks are right here in this section.
Absolutely. And you have to be systematic. Start with the cardiovascular system. Don't jump around.
The cardiovascular response seems contradictory in the textbooks. Some say cardiac output goes up, some say it goes down. Can you clear this up for us?
It's contradictory because it is biphasic. This is the detail that distinguishes a pass from a distinction. At the very beginning of insufflation, at very low pressure, say below 10 millimil Hg, you might actually see an increase in cardiac output.
Why would that happen?
Because that gentle pressure squeezes the splanchnic venous bed, all the blood sitting in the liver and the gut, and it acts like an autotransfusion. It pushes a bolus of volume into the central circulation, increasing preload.
But we don't stay at 10 millimil Hg for the surgery.
No, we go to 12, or more commonly 15. And at 15 millimil Hg, the mechanical compression of the inferior vena cava, the IVC, absolutely dominates. The IVC gets squashed flat against the spine.
So venous return plummets.
It falls off a cliff. And since the heart can only pump what it receives, that's basic Starling's law, cardiac output falls.
So realistically, for the bulk of the surgery, we are dealing with a low output state?
Generally, yes. In a normal volemic patient at 15 millimil Hg, you should assume cardiac output is decreased. But here is the trap, and this is what confuses students in the operating room. They look at the monitor, and the blood pressure, the MAP, is up.
Right. If the flow is down, why is the pressure up? It violates the whole pressure flow X resistance equation in your head.
Exactly. But it doesn't violate it because the resistance part of that equation has gone through the roof. Systemic vascular resistance, or SVR, shoots up massively.
Okay, walk us through why SVR increases so dramatically.
It's a two-pronged attack. One is purely mechanical. You are physically compressing the aorta and the iliac arteries with the gas pressure. It's like stepping on a garden hose. The heart has to pump against that external clamp.
Simple physics.
And the second prong is neurohumoral. The pressure on the kidney, the peritoneum, the absorption of CO2, it all triggers a massive release of stress hormones. You get vasopressin, renin, angiotensin, catecholamines. All of these clamp down the peripheral vessels.
So you have a heart that is filling less, so low preload?
But it's pumping against a brick wall, a massively high afterload.
That sounds like a recipe for myocardial ischemia.
It absolutely is. In a healthy 20-year-old, they tolerate it. Their heart has the reserve to compensate. But you take a 70-year-old with aortic stenosis or coronary artery disease, this high afterload, low preload state is disastrous. It dramatically increases myocardial oxygen demand while the supply is potentially falling.
What about heart rate and rhythm? What are the common arrhythmias we see?
You have to watch out for the vagal reflex. This almost always happens right at the start. The surgeon puts the varus needle in or they insufflate rapidly, and you get a sudden, sharp stretch of the peritoneum.
And the peritoneum is just loaded with vagal nerve endings.
Exactly. I have personally seen profound bradycardia, junctional rhythms, even a few seconds of asystole. Just from the initial insufflation, it can be terrifying.
And the treatment is?
Tell the surgeon to stop immediately. Desufflate. The stimulus is the stretch, so remove the stimulus. If it persists, you might need atropine or glycopyrrolate.
And then later in the case?
Later in the surgery, once things are stable, you actually tend to see tachycardia. That's usually a combination of the hypercarbia CO2, directly stimulates the sympathetic nervous system, and that catecholamine release we just talked about.
So early on, watch for bradycardia. Later on, expect tachycardia.
That's a very good summary.
Okay, let's move to the lungs. Respiratory effects. This feels like the other side of the same coin. The pressure is coming from below.
The diaphragm is the enemy here, or at least it's the victim. You fill the abdomen with gas, and it acts like a piston, pushing the diaphragm cephalid up towards the head. This directly compresses the lung bases.
So the lungs can't expand downwards at all?
Not at all. Miller states that thoracopulmonary compliance decreases by 30 to 50%.
That is a massive drop. The lungs are becoming stiff as a board.
Extremely stiff.
Yeah.
And what that means for you at the ventilator is that to get the same tidal volume in, you need much higher peak airway pressures, or PIP. And because the total lung volume is squashed, your functional residual capacity, your FRC, just plummets.
Which is the recipe for atelectasis.
It is. The lung bases collapse, and that leads to VQ mismatch.
Yep.
You have blood flowing through parts of the lung that are not getting any air.
And then on top of that mechanical crushing, you have the chemical problem.
Right. The CO2 absorption. The gas doesn't just sit in the belly. It diffuses across the huge blood vessel-rich surface of the peritoneum and enters the bloodstream. This causes systemic hypercarbia and a respiratory acidosis.
So how do we fix it? We can't stop the absorption.
You have to ventilate it out. You have to increase the patient's minute ventilation, usually by about 15 to 20%, sometimes more, just to maintain a normal pH and a normal end-tidal CO2. You're constantly fighting this influx of gas.
Yeah, when Artuzio mentions the plateau concept regarding CO2 absorption. This seems like a really important point for troubleshooting during a case.
It's a great clinical pearl. It's something you should watch for on every single case. During a normal laparoscopy, the ET-CO2, the end-tidal CO2, will rise for the first 15 to 30 minutes. Then, it should hit a plateau.
And that plateau represents equilibrium.
Exactly. It's the point where the body's elimination of CO2 through the lungs matches the rate of absorption from the peritoneum.
Okay, so what if it doesn't plateau? What if 45 minutes in, the ET-CO2 is still climbing and climbing, and you're having to chase it with the ventilator?
Then you have to suspect something is wrong. The most common cause, by far, is subcutaneous emphysema. It means the gas has found its way out of the peritoneal cavity and is dissecting into the tissue planes outside the peritoneum.
And the surface area for absorption there is huge.
It's massive and uncontrolled, so the CO2 just keeps pouring into the blood, and you can't keep up. The ET-CO2 will just continue to rise relentlessly.
So watch the trend. If there's no plateau, you need to physically check the patient for crepitus.
Exactly. Feel their chest, their neck, their face. Or, much more rarely, a relentlessly rising CO2 could be a sign of malignant hyperthermia. But clinically, surgical emphysema is your first and most likely bet.
Okay, let's briefly touch on the other systems before we get to management. CNS and renal. This seems important for patients with specific comorbidities.
For the CNS, the one thing you must remember is that intracranial pressure, or ICP, goes up.
Why does it go up?
Two main reasons. One, The high pressure in the chest from the pneumoperitoneum,
Yeah.
and often the Trendelenburg position, impedes venous drainage from the head. The jugular veins can't empty as well. It's a plumbing issue,
A back pressure problem.
a back pressure problem. And two, the hypercarbia we just discussed is a potent cerebral vasodilator. It increases cerebral blood flow, which increases the volume of blood inside the rigid cranium. More volume, more pressure.
So patients with brain tumors, recent strokes, or ventriculoperitoneal shunts.
You proceed with extreme caution. It's often a relative contraindication, and you need to have a serious discussion with the surgeon about the risks and benefits.
And the kidneys, what's happening there?
The renal blood flow drops, and it can drop quite significantly. The pneumoperitoneum directly compresses the renal cortex and also squeezes the renal veins, increasing the resistance to outflow.
So the urine output will drop.
Yes. Miller notes that oliguria low urine output is very, very common intraoperatively.
Does that mean they're going into acute renal failure?
Usually not. It's a functional mechanical change. The pressure is just squeezing the kidney. Once you release the gas at the end of the case, you usually see a brisk return of urine output. The key is to be aware of it so you don't aggressively fluid overload the patient thinking they are dehydrated when actually they're just compressed.
Okay, that makes sense. So we've painted this picture of a patient with a compressed heart, stiff lungs, and squeezed kidneys. Now let's talk action. Part D, anesthetic management. You are the consultant, I'm the resident. We have a patient for a lap toll. How do we assess them preoperatively?
The focus is cardiopulmonary reserve. That's the key word for your exam answer. Can this heart handle the massively increased afterload? Can these lungs handle the dramatically decreased compliance? That's the whole game.
So if you have a patient with severe COPD or known bullous disease,
That's a high-risk patient. The risk of a pneumothorax is higher if a bulla ruptures under the high ventilating pressures. And they might not have the respiratory reserve to wash out the inevitable CO2 load.
and what about obesity? That seems to be the most common comorbidity we encounter.
Obesity is a multiplier for all the respiratory problems. Obese patients already start with a reduced FRC and reduced chest wall compliance. Laparoscopy makes that exponentially worse.
But paradoxically, laparoscopy is often preferred for them.
It is. And this is important for your discussion section in the exam. You have to explain why.
Why then? If the intra-op physiology is worse, why do it?
Because the wound complications of open surgery in obese patients are terrible. You have high rates of infection, dehiscence, incisional hernias, so you accept the significant intraoperative respiratory difficulty to gain the massive postoperative benefit. You just have to be better at managing the ventilator.
Okay, let's talk about the intra-op technique itself. General anesthesia or regional. Can we do a spinal for lap appendix?
You can, theoretically. People have published case reports, but Yao and Artuzio is very firm on this, and it's the standard of care. General anesthesia with tracheal intubation is the gold standard.
Why not an LMA? They are so easy. Everyone loves an LMA for a quick case.
For a true pneumoperitoneum, an LMA is risky for three main reasons. One, you have high intra-abdominal pressure pushing against the stomach. That increases your risk of regurgitation and aspiration.
Right.
Two, you have high airway pressures required to ventilate those stiff lungs. LMAs are designed for low-pressure ventilation. They'll start to leak at the pressures you need.
And three.
And crucially, you need profound muscle relaxation. The surgeon needs a completely still, relaxed abdomen to see and to work safely. If the patient is coughing or straining against an LMA, it's dangerous.
The surgeon is essentially blind if the field is tight.
Exactly. GA with a cuffed endotracheal tube is the safest way to secure the airway, prevent aspiration, and guarantee you can control ventilation.
And why is regional usually a bad idea?
The main reason is the shoulder tip pain. A standard spinal block usually goes up to about the T4 dermatome. The diaphragm is innervated by the phrenic nerve, which is C3, C4, C5.
Way above the block.
Miles above the block. So the patient will be awake with a numb lower body, feeling intense, unbearable pain in their shoulder from the gas irritation. Plus, if they start having trouble breathing from the diaphragmatic splinting, their accessory muscles are blocked. It's a miserable experience for the patient.
Got it. So tube and paralysis, what about our ventilation strategy? Volume control or pressure control? Is there a superior mode?
This is debated, and you can argue either way, but Miller suggests that pressure control ventilation, or PCV, might be superior, especially in obese patients or in steep Trendelenburg.
What's the logic behind that?
In volume control, the ventilator delivers a constant flow of gas. If the pressure hits the alarm limit, it just cuts off. In pressure control, the flow pattern is decelerating. It gives a high initial flow to overcome the resistance, and then the flow tapers off as the alveoli fill. This may improve gas distribution, reduce dead space, and achieve better oxygenation at a lower peak pressure.
And what about PEEP? Should we be using it?
You definitely need some PEEP, positive end expiratory pressure. You're trying to counteract that drop in FRC and keep the alveoli at the lung bases from collapsing. 5 to 10 centimeters of water is pretty standard.
But there's a downside to PEEP, too.
There is. You have to be careful. PEEP increases intrathoracic pressure, which can further reduce venous return to the heart. So if you add 15 of PEEP to a 15 mmol Hg pneumoperitoneum, you might completely tank the blood pressure. It's a balancing act, as always.
Let's talk about positioning, the second part of our triad. Trendelenburg or head down, and reverse Trendelenburg, head up.
Right. Trendelenburg is used for most pelvic surgeries. Gyne, urology. The idea is that the guts fall away from the pelvis and give the surgeon a clear view. But this is the danger position for the anesthetist.
Why is it so dangerous from our end?
The diaphragm is pushed up even harder by the gravity of the bowels. The lung compliance drops even further. You get facial and laryngeal edema from the venous congestion. And here is a specific testable complication to watch for: endobronchial intubation.
How does that happen? The tube is secured.
The diaphragm moves up, the mediastinum shifts, and the carina itself moves cephalad towards the head. But the tube is fixed at the teeth. So effectively, the carina moves up to meet the tube, and the tube gets pushed deeper, almost always into the right mainstem bronchus.
So after you position the patient in steep Trendelenburg, you must recheck breath sounds bilaterally.
Mandatory. Every single time.
And reverse Trendelenburg, that's for upper abdominal stuff like cholecystectomies.
Correct. Here, the main risk is hypotension. The head is up, the blood pools in the legs due to gravity, and venous return drops even more than just with the gas alone. You often see the blood pressure dip right as the bed tilts up. Be ready for it.
What about lithotomy position? We see that often combined with Trendelenburg for gyne and urology cases.
Yes, and that adds its own set of dangers. The primary concern in lithotomy is nerve injuries. You have to be incredibly careful to avoid pressure on the common peroneal nerve against the stirrup and the saphenous nerve if the leg is compressed medially.
I've also heard of compartment syndrome.
It's rare, but it can happen in very long cases. The other thing to watch for is at the end of the surgery. If the team lowers the legs too quickly from the high lithotomy position, you get a massive sequestration of blood back into the lower limbs, causing sudden, profound hypotension.
Okay, a lot to think about there. Moving on to Part E complications, we touched on vagal reflexes and arrhythmias, but let's talk about the big, scary one, gas embolism. This is a very high-yield topic for the exam.
It is rare, fortunately. But it is so rapidly fatal if missed that examiners expect you to know it cold. It usually happens right at the start during insufflation. The venous needle hits a vessel like the iliac vein or a vessel in the liver instead of the free cavity.
So how do I diagnose it? The textbooks all talk about the mill wheel murmur.
A churning, splashing sound heard over the precordium. It sounds like a water wheel. But honestly, if you were waiting to hear that with your stethoscope, the patient is probably already dead. You need to catch it on the monitors, and you need to catch it instantly.
So what is the very first sign I will see?
A sudden, precipitous drop in end-tidal CO2.
Wait, let's pause there because that confuses people. We are injecting CO2. If we inject it into a vein, shouldn't the exhaled CO2 go up?
That's the classic trap. And it's a brilliant question. If you absorb CO2 slowly via the peritoneum, the TCO2 goes up. But a gas embolism is a mechanical blockage. A large bubble of gas goes to the right ventricle and blocks the pulmonary artery. It's an airlock.
So blood flow to the lungs just stops.
Correct. Cardiac output to the lungs stops. If no blood is going to the lungs to participate in gas exchange, then no CO2 is coming out of the mouth. So the TCO2 trace on your monitor drops to near zero. It looks like a cardiac arrest or a disconnected breathing circuit.
That is a critical distinction. Absorbing gas equals high at TCO2. Embolism blocking flow equals low at TCO2.
Exactly. You will also see profound hypotension, desaturation, and often tachycardia followed by bradycardia and arrest.
What is the drill? The immediate treatment protocol.
Number 1, stop insufflation immediately. Scream at the surgeon to stop. 2, turn the patient to 100% oxygen. Flooding the lungs with oxygen helps establish a gradient to wash nitrogen out of the bubble, making it smaller, and maximizes oxygenation of whatever blood is getting through. And 3, the Durant position.
Which is?
Left lateral decubitus with the head down, or Trendelenburg.
Why that specific position?
It's pure physics again. You want the right ventricle outflow tract, which is the pulmonary artery, to be in the most dependent position, below the main body of the ventricle. By putting the patient's left side down, the bubble, which floats, will hopefully rise to the apex of the right ventricle, away from the exit. You are trying to trap the bubble in the corner of the heart so that blood can flow underneath it.
That's brilliant mechanics. And if you happen to have a central line in the right atrium,
You try to aspirate the gas, but realistically, in a code situation, the position and high-quality CPR are your main tools.
let's address another common intraoperative annoyance, subcutaneous emphysema. We mentioned the loss of plateau sign earlier. How dangerous is this really?
Usually, it's just cosmetically alarming. The patient puffs up like the Michelin Man. You can feel that distinctive Rice Krispie crepitus under the skin of their chest and neck. The main physiological issue is the persistent, hard-to-control hypercarbia.
You're just chasing your tail with the ventilator.
You are. You might be ventilating like crazy and still have a PEC-O2 of 60 or 70 because the absorption surface area is just so huge.
Are there airway implications we should worry about?
That is the real danger. If the air tracks up the chest wall into the neck, it can cause so much swelling that it compresses the pharynx or the trachea, or simply the sheer volume of gas in the neck tissues can completely distort the anatomy. If you extubate that patient and they obstruct, you might never get the tube back in.
So what's the rule of thumb for extubation?
If there is significant neck emphysema, you must verify a cuff leak before you even think about extubating. Deflate the cuff completely and listen for air moving around the tube. If it's tight, if there's no leak, that patient should stay intubated and sedated in the ICU until the gas has had time to absorb.
Before we leave complications, let's talk about pneumothorax. It's rare, but how on earth does it happen from a procedure in the belly?
There are a couple of ways. One is the porous diaphragm syndrome. Some people have congenital defects or small fenestrations in the diaphragm that allow the pressurized gas to track directly from the abdomen into the chest.
And the other way?
Barotrauma from our own high-pressure ventilation trying to overcome the stiff abdomen. Or, very rarely, a direct surgical injury to the diaphragm.
And the signs would be?
A sudden increase in airway pressures, hypoxia, and hemodynamic instability. It can look a lot like a mainstem intubation or a severe bronchospasm. You need a high index of suspicion.
Okay, moving to post-operative complications. We promise the patient less pain, but they often wake up complaining of severe shoulder pain.
The shoulder tip pain is classic. It occurs in up to 30 to 50% of patients, and as we said, it's referred pain from the phrenic nerve irritation caused by that carbonic acid.
So how do we manage it? It doesn't seem to respond well to opioids.
It doesn't. NSAIDs can help, but the best management is intraoperative. The surgeon should try to actively evacuate all the residual gas before closing the last port. Some surgeons will perform a pulmonary recruitment maneuver, giving a big, sustained breath to push the gas out of the subdiaphragmatic space right before closure.
And what about PONV, post-operative nausea and vomiting?
Laparoscopy is an independent risk factor for PONV. The bowel manipulation, the peritoneal stretching, the gas itself, it all contributes. So you should be aggressive with prophylaxis, especially in high-risk patients.
A multimodal approach.
Absolutely. Dexamethasone after induction, ondansetron near the end, maybe even consider Tiva, total intravenous anesthesia with propofol instead of Valdol gas if the patient has a strong history of PONV.
All right, let's move to Part F, special situations. We have about 10 minutes left. Let's talk pregnancy. This used to be a big no-no.
Historically, yes. People were terrified of causing fetal acidosis or inducing premature labor. But now, the consensus from Miller and Yao is that it's safe to perform in any trimester, although the second trimester is generally considered the sweet spot.
Why the second trimester?
The uterus isn't so big yet that it completely obscures the surgical view, but the critical period of organogenesis from the first trimester is over, so any theoretical pterogenicity risk is lower.
So what are the specific modifications for the anesthetist?
You need to monitor the fetal heart rate continuously, if possible. You must keep the intra-abdominal pressure lower than usual, say 10-12 mmHg, to avoid compressing the uterine blood flow. And obviously, you have to maintain a left uterine displacement tilt to avoid aortic caval compression.
And what about managing the maternal CO2?
This is key. CO2 crosses the placenta readily. If the mother becomes hypercapnic, the fetus becomes acidotic. And fetal acidosis is a potent cause of fetal cardiac depression, so you must keep the mother normocapnic. You can't allow for permissive hypercapnia in a pregnant patient.
And what about the patient with serious cardiac disease? Say, severe aortic stenosis.
That is probably the highest risk category of patient we can do this on. Patients with a fixed cardiac output, like in severe AS, cannot tolerate the drop in preload or the massive increase in afterload. They can spiral into profound ischemia and cardiac arrest very, very quickly.
So do we just cancel the case and insist on an open procedure?
If it's an emergency, you can't. But you need to prepare for war. An arterial line is absolutely mandatory. You might even consider a CVC or a T, a transesophageal echo, as Miller suggests, to monitor cardiac filling and function in real time.
And what about the Pneumoperitoneum itself?
You manage the IAP incredibly strictly. Keep it as low as humanly possible, maybe 8-10 mmHg, or you discuss with the surgeon using gasless laparoscopy.
Gasless? How does that work?
It exists. It's a mechanical lift system that uses retractors to physically pull the abdominal wall up like a tent, creating a workspace without insufflation.
That sounds like a fantastic workaround.
It can be. Surgeons often dislike it because the view isn't as good. It's not a perfect dome like you get with gas. But for a patient with severe cardiac disease, it might be the only safe option.
Let's touch on daycare surgery. Laparoscopy is the darling of ambulatory centers.
Absolutely. Fast tracking is the name of the game. You want rapid emergence, minimal pain, no nausea, and no hangover effect.
So our choice of agents should reflect that.
Short-acting is always better. Desflurane or sevoflurane are preferred over isoflurane because they wash out much faster, especially in obese patients who might store the gas in their fat. Or Tiva with propofol and rembifentanil is excellent for reducing P-on-V and giving a really clear-headed recovery.
And pain control for discharge.
You can't rely on IV morphine if you want them to go home in 4 hours. You need a multimodal approach. The surgeon must infiltrate local anesthetic at all the port sites. You use regular paracetamol and NSAIDs, and maybe a regional techniques like a tap block, a transversus abdominis plane block, if applicable.
Okay, Part G, exam integration. We're in the final stretch. How do we synthesize all of this for that 20-mark answer?
You need visuals. If this is a written exam, do not just write endless paragraphs. Draw the pneumoperitoneum physiology diagram.
Describe that for us so the listener can visualize it for their own notes.
Okay, draw a central box in the middle of your page and label it raised IAP. Then draw arrows radiating out from it to 3 other boxes: heart, lungs, and kidney.
Okay, got it.
Under the heart box, draw an arrow pointing UP and label it afterload SVR. Then draw an arrow pointing down and label it preload at IAP 15 mmHg under the lungs box. Arrow down, label compliance. Arrow UP, label PIP under the kidney box. Arrow down, label RBF, renal blood flow. Under the kidney box, this simple diagram on one page shows the examiner immediately that you understand the systemic nature of the problem.
And tables. Examiners love tables for a quick mark grab.
A comparison table of open versus laparoscopy is essential.
Parameter, column 2, laparoscopy. Column 3, open, then your rows. Post-op pain, less in lap. Intra-op hemodynamic stress, higher in lap. Post-op pulmonary dysfunction, less in lap. Return of bowel function, faster in lap. It shows you grasp the fundamental trade-offs.
And for the Viva, what are the common traps we need to avoid?
We covered the big ones. Track number 1, does cardiac output go up or down? Your safe answer is, it is biphasic. It may rise transiently at low pressures due to autotransfusion from the splanchnic bed, but it consistently decreases at clinically used pressures of 12-15 mmHg due to mechanical obstruction of venous return.
Nuance is key, not a simple yes-no.
Never. Trap number 2, why did the ATCO2 drop suddenly? Your safe answer. My first thought must be to rule out a catastrophic event like a gas embolism or profound hypertension cardiac arrest, both of which would cause a critical drop in pulmonary blood flow. Do not say the machine is broken first. Think physiology.
And the third trap.
Is pregnancy an absolute contraindication? Your safe answer, no. It is not an absolute contraindication, provided specific precautions are taken regarding maintaining left uterine displacement, using lower insufflation pressures, and diligently maintaining maternal normocapnia to protect the fetus from acidosis.
That is fantastic. It's all about showing confidence and nuance. You can't just say CO drops. You have to explain when and why.
Precisely. The examiner wants to see that you are thinking like a perioperative physician, not just a technician. You are managing the complex interacting physiology, not just turning the dials on the anesthetic machine.
So to recap our deep dive today for everyone listening, laparoscopy is minimally invasive for the surgeon, but maximally invasive for the physiology, or the triad. Pneumoperitoneum, position, CO2 absorption. These 3 things explain everything.
Everything.
Cardiovascular effects. A dangerous combination of high afterload and low preload, putting the heart at risk of ischemia.
Low compliance, high PIP, and a constant battle against hypercarbia.
It has to be GA, with an ETT, profound muscle relaxation, careful positioning, and a hawk-like watch on the IAP.
Yes.
And complications. Be absolutely terrified of the sudden ETCO2 drop. Think embolism first.
And remember my final thought for your exam paper conclusion. Watch the IAP and the ETCO2. Those two numbers tell you the story of what is happening inside that patient. If the IAP is 25, the kidneys are being crushed. If the ETCO2 is not plateauing, the gas has escaped into the tissues. Listen to your monitors. They are speaking to you.
Brilliant. Thank you so much for walking us through that maze of physiology. To our listener, good luck with the Gujarat University exams. Go practice drawing those diagrams. You've got this.
Happy study.